Good afternoon, everyone, and thank you for joining us for today's webinar titled Implementation of Antibiotic Stewardship Activities in Critical Access Hospitals. Before we get started, I wanted to inform you that CE is available for this webinar. However, before I can show you the access information, I'd like to share with you the following statements and disclosures. I will now display them on each title slide for less than a minute so you can read over the statements for yourself before we begin. All right, and that is the end of our CE information. If you have any further in-depth questions regarding CE and how to obtain units, please contact the TCEO at tceo@cdc.gov. Just a few housekeeping items that we want to get into before we get started. Please use the chat feature located on the bottom of your screen for technical questions only. And please only put into the Q&A box content-related questions. Now, we do have a tight presentation lineup today. And in case we do not get a chance to address the Q&A, putting questions into the Q&A box will be easier for our SMEs to go ahead and get those questions answered for you. So with that being said, I will go ahead and pass it along to our first speaker. Arjun, go ahead and take it away.
Absolutely, and if you can maybe switch to the next slide, Monica. So I'm Arjun Srinivasan from the Division of Healthcare Quality Promotion at CDC. Pleasure to have all of you with us today and recognizing both the confluence of two great things, antibiotic stewardship and rural health. Been a pleasure to host these webinars in coordination with HRSA's Federal Office of Rural Health Policy. Next slide, please. And we come together every year to talk about antibiotic use and resistance because this is a huge and continuing problem in the United States. Every year, nearly 2.9 million infections with these resistant organisms, nearly 36,000 deaths. Add to that the problem of Clostridioides difficile, which is driven by the same factors that drive antibiotic resistance, antibiotic use, and the spread of infections. And that's another over 200,000 cases and hospitalized patients and 13,000 deaths. Important to note that though we are in the midst of a pandemic and COVID is clearly occupying a tremendous amount of our bandwidth right now, it's always to remember that one, patients who get two, that resistance was a problem that predated COVID and will be here long after COVID. So this is something that we have to continue working on an ongoing basis to make progress. Next slide, please. In recognition of that ongoing need for work in this space, the United States has just updated our National Action Plan for combating antibiotic-resistant bacteria. The initial plan was launched in 2015, ran through 2020, and in recognition of the ongoing need for all of this very important work to prevent antibiotic resistance and reduce antibiotic resistance, we have revised that and updated that plan to cover the coming 5 years. Next slide, please. And today we're really here focused on the efforts in goal 1 to slow the emergence of resistance. We know that this is the key, is to make sure that we can implement it consistently. And that is really the goal of what we're talking about here today. And you can see that this includes both our work on healthcare associated infections, but also the important work that we're talking about today, which is our efforts to improve antibiotic use through antibiotic stewardship efforts. Next slide, please. And so with that, I'm going to turn it over to one of our fantastic partners, Natalia Vargas from the Federal Office of Rural Health Policy. Natalia?
Thank you, Arjun, for that great introduction. And if we can move to the next slide, please. Before introducing some of the work that we do at the Federal Office of Rural Health Policy, or FORP for short, I want to take a moment to highlight National Rural Health Day, which we're actually celebrating tomorrow as an opportunity to spotlight healthcare initiatives that benefit rural Americans. If you're interested in seeing additional virtual events such as this one that highlight rural health issues, please visit the website listed at the bottom of the slide. Next slide, please. So in today's webinar, we will be discussing the 2019 NHSN annual survey results and explore strategies for enhancing stewardship activities in critical access hospitals. So I wanted to help frame this conversation by providing some context about the common interests that connect HRSA with CDC as it relates to antibiotic stewardship. Since the late 80s, FORP has advised the Department of Health and Human Services on healthcare issues impacting rural communities. And in this capacity, our goal is to work in collaboration with other HHS agencies. And I'm very pleased to say that we have developed a particularly strong relationship with the CDC. This work, though, is also in alignment with HRSA's mission and with the goals of the 2020 HHS Rural Action Plan to help increase access to care for underserved populations by making healthcare in rural America more affordable, more accessible, and higher quality. And we accomplish this through a long range of programs, but today I will focus on the work that we do specifically with critical access hospitals. Next slide, please. So this slide illustrates the breadth and the depth of our work at a national level across 45 states. But worth highlighting is the variability that we see among the 1,300 plus CAS participating in our program. This will give you a very good sense of what that area of the country is like, but other areas in the country will have a very different look and feel. And this also applies to the health services available in those areas. The point here is that we have a very unique challenge. We can't really dichotomize infection control into rural versus urban hospitals, because at least for the rural hospitals, there are so many factors that just make this work slightly more complex. Next slide, please. To tackle the complexities with the variability that we see in rural areas, FORP developed the MBQuip program in 2011 through our long-standing FLEX program, which was already in place to support critical access hospitals. MBQuip primarily underscores our FLEX quality improvement aims across the 45 states that have critical access hospitals. And currently, our program focuses on a common set of rural relevant hospital metrics within the 4 measure domains that you see depicted on the right. Antibiotic stewardship is one of the quality improvement activities that would fall under the patient safety and patient domain. Next slide, please. So with that context in mind, I want to home in on the 4 antibiotic stewardship efforts that follow the progression pictured in this timeline here. And I want to point out that the motivating force for tackling the implementation of antibiotic stewardship in critical access hospitals was based on earlier efforts by my CDC and HHS colleagues, which actually paved the way for the next 3 years in which we tracked how critical access hospitals were doing in meeting the CDC core elements. Since we started this work in 2014, we have been able to go from 18% of CAS meeting the core elements to almost 80 by 2019. And while we're incredibly proud to move the needle in antibiotic stewardship implementation, recent government-wide efforts put the spotlight back on us to address the judicious use of antibiotics. In fact, earlier this year, I participated in the development of the Government Accountability Office antibiotic resistance report that called for increased collaboration among HHS agencies. And one way in which HRSA is actually answering that call is by laying some tracks alongside with my CDC colleagues here on this call to address the implementation of antibiotic stewardship programs in critical access hospitals. Next slide, please. Very briefly, I want to give you a perspective snapshot of what we see as opportunities to reach the blue bubble on this slide. So in a nutshell, our office will be adding to the timeline arrow from the previous slide by addressing 3 main goals. In the next 5 years, we will be improving capacity across our 45 participating states to use data from NHSN to demonstrate actual improvements on antibiotic use. We will be improving critical access hospital reporting rates on NHSN and addressing challenges in rural hospitals in order to improve uptake of the core elements. So the presentations that you will hear next will help us zoom in on the factors that ultimately influence these 3 main goals, particularly as we take a deeper dive at the national data that is available through 2019, and also help us chart the way forward by exploring tangible examples that can help our critical access hospitals improve the core element uptake. Next slide, please. Contact information and ways to get in touch with our office. Next slide, please. And also a little bit about our agency. And now with that, I will turn it over to Erin and Emily. Next slide, please. They are our power team presenters who will help us peel apart the NHSN onion. So thank you for taking that role. And with that, I'm very pleased to introduce Erin O'Leary. Thank you.
Thank you, Natalia, and hello, everybody. If you could go ahead to the next slide, that would be great. So thank you all for joining. Today's webinar will discuss the uptake of hospital core elements in the United States, stratified by facility type, bed size, and teaching status, and then provide practical suggestions for enhancing stewardship activities in critical access hospitals. Next slide, please. So we have no financial relationships or disclosures. Next slide. So in 2014, CDC called on all hospitals in the US to implement antibiotic stewardship programs and released the core elements of hospital antibiotic stewardship programs to help facilities achieve this goal. Core elements outline structural and procedural components that are associated with successful stewardship programs. And they were updated in 2019 to incorporate new evidence and lessons learned over the previous years, including new priority examples for select elements. The 7 core elements include hospital leadership commitment, accountability, pharmacy expertise, action, tracking, reporting, and education. Next slide. Hospitals participating in the patient safety component of the National Healthcare Safety Network complete an annual online survey, which includes questions on facility demographics, laboratory practices, infection control practices, and questions that are specific to antibiotic stewardship programs. The survey is typically completed by a hospital's infection preventionist, but staff completing the stewardship portion are encouraged to request assistance from pharmacists and our physicians who focus on stewardship or infectious diseases, or members of the pharmacy and therapeutics team. Next slide. Annual surveys summarize information and events taking place in hospitals during the previous full calendar year. So 2019 surveys, for example, are completed by hospitals in early 2020 for activities taking place in 2019. The antibiotic stewardship portion this past year's survey is composed of 10 required questions and 9 optional questions. And CDC uses responses to the required questions to assess whether facilities meet criteria for each of the 7 core elements. And then we track core element uptake by comparing percentages of facilities meeting each core element and all 7 core elements each year. Next slide. Among all hospitals responding to the annual survey, uptake of all 7 core elements increased from 40.9% of hospitals in 2014 to 88.9% of hospitals in 2019. So we've seen a lot of progress there. Next slide. The percentage of hospitals meeting all 7 core elements varies by state. In 2019, Montana reported lowest uptake at 70% of facilities meeting all 7 core elements, followed by Wyoming, Kansas, Hawaii, and South Dakota. Then there were 12 states that had more than 95% of hospitals reporting that they met all 7 core elements. Next slide. Hospital uptake of all 7 core elements varies by facility type, hospital size, and hospital teaching status. And in general, smaller, non-teaching, and critical access hospitals are less likely to report meeting all 7 core elements compared to their larging teaching counterparts. Next slide. With that said, facilities have made huge improvements since 2014. In 2014, only 19.6% of critical access hospitals met all 7 core elements, compared to almost 80% in 2019. Next slide. This chart shows the percentage of hospitals meeting each individual core element by year. In 2014, leadership commitment was the core element with the lowest uptake. But since 2014, education has been the core element with lowest uptake, although percent uptake has increased from 62% in 2014 to 93% in 2019. So great progress among each of these core elements. Next slide. This chart shows 2019 uptake of individual core elements by facility type. So uptake is slightly lower in critical access hospitals for each of these core elements, but overall there is very high uptake of all individual core elements, regardless of facility type. Next slide. So diving into individual core elements, we'll start with hospital leadership commitment. Priority examples include giving program leaders time to manage the program and conduct daily stewardship interventions, providing resources, including staffing, to operate the program effectively, having regular meetings with a stewardship leader or leaders to assess the resources needed to accomplish the hospital's goals for improving antimicrobial use, appointing a senior executive leader to serve as a point of contact or champion for the program to help ensure it has the resources and support needed to accomplish its mission, and reporting stewardship activities and outcomes to senior leadership in the hospital board on a regular basis. Next slide. This table shows the percentage of hospitals meeting priority examples of hospital leadership commitment on the survey. Most facilities report having leadership that has demonstrated commitment by allocating information technology resources, and fewer facilities report that their physician or pharmacist leaders have antibiotic stewardship responsibilities listed in their contract or job description. And critical access hospitals are less likely to meet each of these priority examples compared to general acute care hospitals, children's hospitals, and surgical facilities. Next slide. Emily, I'll pass it over to you.
Yeah, so thank you, Erin. And thanks everybody for joining and for the opportunity to present here today. So as Erin highlighted, I'm going to get to physician and pharmacist expertise and support, but I think the leadership commitment to stewardship most directly impacts the ability to have strong pharmacy and physician co-leadership. And I'd refer you to the CDC's implementation of antibiotic stewardship core elements in small and critical access hospitals to get some ideas that Erin has already outlined for different types of leadership commitment. My practical advice to you is going to be to insert yourself into quality improvement initiatives that really have to be happening, things such as sepsis management, core measures that have to be reported, and figure out a way to creatively insert yourself and create a reporting structure so that you report to the C-suite, to executive leadership, so that they see you, they hear you, they know what you do, and then that will translate over time into getting appropriate resources, money to pay a physician and a pharmacist to do this type of work. Next slide. I'd also encourage you to look at the National Quality Partners Playbook for Antibiotic Stewardship in Acute Care Hospitals that was published in 2016 and is readily available online. This is a great document that sort of goes beyond some others and identifies for all of these core elements potential barriers and suggested solutions to work around some problems in identifying leadership commitment, physician or pharmacy leaders, et cetera. Next slide. And as I said before, I really think the goal should be to outline a policy for stewardship in your hospital. And within that policy, that is a way to incorporate yourself or incorporate a reporting structure where you directly insert yourself and create exposure in reporting to leadership. I've created stewardship program policies at both of the hospitals where I work, and a policy for stewardship really is the who, what, when, where, and why. So it outlines in these policies the background, purposes, and goals of the stewardship program, who you are, who's on the team, the integral role of the pharmacy and the physician co-leaders, where you fall in the organization chart, who you are responsible or accountable to, and who you report to. The policy can describe the interventions, the what, the actions that you do, what you're responsible for tracking, and again, who you report it to. And I find that if you outline a policy and it gets approved within your hospital by the appropriate committees, that is setting the stage or creating the infrastructure to report to hospital leadership and directly get their buy-in and ultimately their money and resources. Next slide. So here are just two examples. This is just the front page of the policies for the antimicrobial stewardship programs that I co-lead, on the left at the Salt Lake City VA and on the right at the University of Utah Hospital. And I'm happy to provide these examples and follow up to anyone who would like them. But again, you don't need to recreate these. There are templates that exist and examples available. And I would encourage this as a way to create a conversation and a touch point with leadership. This will fulfill your core element, but more importantly, create and set the stage to engage with leadership and get the buy-in and resources that you need to be an effective stewardship program. Next slide. And I'm gonna hand it back to Erin.
Thanks, Emily. So jumping into the next core element, which is accountability, most hospitals have found a model of co-leadership between a physician and a pharmacist to be effective. If a non-physician is the stewardship leader, hospitals can designate a physician as point of contact and support for the non-physician program leader. And regular stewardship rounds for co-leaders or the non-physician lead and supporting physician can strengthen overall program leadership. And rounds can be expanded to include prescribers, and a little later on, Emily will discuss how this can be adopted during times of COVID. Next slide, please. So survey results show that co-led stewardship programs are more likely to meet all 7 core elements compared to physician-led, pharmacist-led, and other-led programs. In 2019, 94% of hospitals with co-led programs met all 7 core elements, compared to 89% of hospitals with physician-led programs and 87% of hospitals with pharmacist-led programs. Next slide, please. And co-led stewardship programs are becoming more common. There were only 23% of hospitals in 2015 that reported having a co-led program, compared to 61% in 2019. Next slide. And while 61% of hospitals nationally reported having a co-led program in 2019, results differ by facility type and hospital size. And only about 39% of critical access hospitals reported having a co-led stewardship program in 2019. And next slide.
So I'll take
Emily,
over.
back to you.
Yeah, thank you. So I'll take over here. So thinking about accountability, and I completely agree with Aaron, co-led programs are ideal. And so how do you find a physician leader, and realizing that in many rural areas or in critical access hospitals, there may not be, and oftentimes is not, an ID physician on site. I would just say you do not need to be an ID trained physician by any means to do stewardship. And I'd encourage you to think creatively outside of the box, maybe identify a hospitalist, or is there a advanced practice clinician like a nurse provider or a nurse practitioner or a PA who is passionate about quality improvement, patient safety, who can take on that sort of provider role for you. I would encourage, if there's a provider that's interested and not trained in stewardship or infectious diseases, to seek out antimicrobial stewardship training. And if you go back to the National Quality Forum Antibiotic Stewardship Playbook, there is a list of antibiotic stewardship training courses, online and in person, for pharmacists and physicians. I'd also think creatively about maybe having multiple clinical champions or multiple physician leaders, and pull them in when you need them from varying areas where you want to make an impact. For example, intensive care units, some of your surgery colleagues, or in the emergency room. Another idea is to contract with infectious diseases groups who provide leadership and expertise off-site through telemedicine or tele-stewardship platforms. And they can be a physician leader remotely, but provide you with some backup and expertise. And I'd also encourage folks to enroll in collaboratives geographically or within your state or your geographic area, or in programs that have an ECHO or a mentorship type model, somewhat like telemedicine, but also a little bit different, where it may be more of a peer-to-peer type relationship, and you can mentor each other. But I'd still argue, ideally, even if you do some of those remote type options, you are always going to need, or ideally need, a local leader on site. So try and pull in a physician leader who can then participate with off-site, potentially infectious diseases, tele-stewardship, mentorship, or an ECHO model. Next slide. And I'm going to come back to that. Ideally, again, to make this sustainable, to keep this person engaged, you really need dedicated time. And to me, time and money to do this are really the same thing. Accountability, when somebody is paid for it and has a reporting structure for stewardship, that is what's going to keep them engaged. So really need to work through that with some of your hospital reporting. Next slide. I'll hand it back to Erin.
Thanks, Emily. So heading forward, we are at our pharmacy expertise core element, and highly effective hospital antibiotic stewardship programs have strong engagement of pharmacists. So CDC has several posters highlighting key stewardship interventions for hospital pharmacists, which can be found online at cdc.gov/antibiotic use, or by following the link at the bottom of this slide. Next slide, please. There is high uptake of the pharmacy expertise core element across all facility types. Critical access hospitals are less likely to have co-led programs, but they are more likely than other facility types to have pharmacy-led programs. Next slide, please. Emily, back to you.
Thank you. So thinking about the pharmacy co-leader and expertise, again, in many settings, and we even have limited access here, you may have limited access to infectious diseases and stewardship trained pharmacists. And I think the same principles hold if you have somebody that is passionate about leadership, passionate about patient safety, quality improvement, and antibiotic use. That person is perfect, and some of these skills can be taught or can be harnessed, some of the expertise and backup through tele-stewardship and ECHO and collaborative models. I'd also, again, point you back to the National Quality Forum Playbook to seek out antimicrobial stewardship training specifically focused for pharmacists who may need it on site or contracted through your hospital, again, who may not have that training as part of their education. But I'd really point out, again, the pharmacist role is integral. I strongly believe in the co-leader model, but the pharmacist is really, really integral, because in many places, the pharmacist is the one doing the day-to-day work. So I'd focus on getting a really passionate pharmacist first with leadership skills, who's willing to learn and put themselves out there and engage with providers across your facility. Next slide. I did want to give some practical advice and give an example of how we have extended our arms or our reach of our stewardship program out and harnessed some of our non-traditional stewardship or non-ID pharmacists to do some of the work for us, and things that I would encourage you to creatively think about. At the Salt Lake City VA, we have an emergency emergency room pharmacist who is interested in helping us with part of our stewardship program. And we created an intervention where the emergency room pharmacists run a report of positive urine cultures, or actually all urine cultures that were collected in the emergency room. And they do that during weekdays. Then they go through and sort of break them into the positive urine cultures and the negative urine cultures and go through the charts. And for those that are negative, really focus on looking through clinically what was going on and stopping antibiotics often. And will call the patients and talk to the physicians and often get those antibiotics stopped. For patients who have positive cultures, they go through and say, you know, was this appropriately collected? Did this patient potentially have asymptomatic bacteriuria? And then again, document some interventions and call patients. And if there's no evidence of symptoms, get those prescriptions stopped or get the patient to stop taking it. So this has really been a way for us to harness physicians that are not classically associated with the stewardship program to improve antibiotic use. Next slide. And back to Erin.
Mute. All right. So the 2019 core element update includes examples of interventions which are classified as priority and other. The other interventions are categorized as infection-based, provider-based, pharmacy-based, microbiology-based, and nursing-based interventions. Priority interventions include prospective audit and feedback, pre-authorization, and facility-specific treatment recommendations. Evidence demonstrates that prospective audit and feedback and pre-authorization improve antibiotic use and are recommended in guidelines as core components of any stewardship program. And facility treatment guidelines can be important in enhancing the effectiveness of prospective audit and feedback and pre-authorization. The 2019 update emphasizes the importance of actions focused on the most common indications for hospital antibiotic use, including lower respiratory tract infection, urinary tract infection, and skin and soft tissue infection. And the antibiotic timeout has been reframed as a useful supplemental intervention, but it should not be a substitute for prospective audit and feedback. And a new category of nursing-based actions is added to reflect the important role that nurses play in hospital antibiotic stewardship efforts. Next slide, please. So similar to other facility types, 92% of critical access hospitals report having facility-specific treatment guidelines, but they are less likely to have prospective audit and feedback and pre-authorization interventions in place. Next slide. And Emily, back to you.
Thank you. So Erin just showed that it's more common for critical access hospitals to have infectious diseases focused clinical guidelines, less likely to have prospective audit and feedback. And so I wanted to talk about sort of reframing that a little bit, or practically thinking about syndrome-specific stewardship. So stewardship focused on the most common infectious syndromes that are seen in acute care hospitals. That's community-acquired pneumonia, urinary tract infections, and skin and soft tissue infections. And reframe some of the way to think about it as developing guidelines, which many places have done, but using those guidelines as a framework to do prospective audit and feedback and go back to your guidelines, you know, prospectively review patients with these diagnoses and use your guidelines to reinforce what appropriate sort of diagnostic parameters and treatment parameters should be in your prospective audit and feedback. As many may know, the syndrome specific stewardship is really in the United States, driven by these three common diagnoses. And there are clearly significant opportunities for improved antibiotic use. Specifically, community-acquired pneumonia and urinary tract infections tend to be overdiagnosed based on prevalence of abnormalities on chest x-rays, which may be misinterpreted as pneumonia, and asymptomatic bacteriuria, which drives a lot of misdiagnosis as a symptomatic UTI and use of antibiotics. There are also clear guidelines and best practices that have been published specifically by the Infectious Diseases Society of America, and lots of examples available of guidelines that have been locally implemented elsewhere. So it's developing a guideline and a framework for doing prospective audit feedback around these syndromes is fairly straightforward given the plethora of data and best practices that exist, and really doesn't require ID expertise. Next slide. So when you do syndrome-specific stewardship or focus on those 3 diagnoses, like I alluded to, there are really common themes that come out. The diagnosis, so that gets at the right patient. Is this a patient that really has a bacterial infection for which antibiotics would be beneficial or helpful? What is the right drug or drug selection, as many of these patients, if they truly do have these infections, are often treated with overly broad spectrum antibiotics. Examples would be community-acquired pneumonia, patients getting piperacillin and tazobactam when they really just have community organisms for which ceftriaxone would be appropriate. Another example may be skin and soft tissue infections, so non-purulent cellulitis, usually due to streptococci, where patients may inappropriately get gram-negative coverage or MRSA coverage. And then duration of therapy. Really focusing in on the shortest known effective duration, which for these diagnoses, there's quite good evidence and guidelines to direct you to the shortest effective duration. Next slide. So I would point you to, so on the right here is a table that is available in the CDC's core elements of stewardship for rural and critical access hospitals. Again, focusing on these 3 diagnoses and key opportunities to improve antibiotic use in each. And again, focusing, like I mentioned, on the right patient, the right drug, and the right duration. So there's diagnostic considerations, empiric antibiotic therapy guidance, and durations of therapy. So it gives you some tips for each diagnosis on where to focus and what some of the common mistakes and pitfalls are. I wanted to give an example of a community-acquired pneumonia guideline and intervention that I was part of in our stewardship program implemented at the University of Utah, and how we have dovetailed that with prospective audit and feedback. And then at the end, when we get to the measurement and reporting, show you how we measured the impact of this intervention, and we're able to then report or feed that information back to hospital leadership to gain some resources. So we had a goal of developing and implementing a single, what we called a best practice pathway. Essentially, what is our institutional diagnosis and treatment guideline for community-acquired pneumonia? Because as of several years ago, we did not have one. Our plan, once we implemented this, was sort of after the implementation, we wanted to look at the impact of our pathway on intravenous antibiotic duration and total antibiotic duration. So what was the duration or the days of IV antibiotics in the hospital, and then including post-discharge antibiotics, the total duration for community-acquired pneumonia. We wanted to look on some hard clinical outcomes like the patient's length of stay, the cost of their stay in our hospital, and then we looked at what is sometimes referred to as balancing measures. What were our readmission rates in this population and our mortality rates? Next slide. Our targets clinically, again, getting back at the diagnostic, the empiric antibiotic, and the duration of therapy opportunities for these common syndromes were, these were our targets that are listed here. So thinking about empiric antibiotics, we found that patients with community-acquired pneumonia were treated with overly broad spectrum antibiotics, often due to being labeled as having healthcare-associated pneumonia based on prior diagnostic guidelines, and this category, which has since been retired and is not incorporated in the newest community-acquired pneumonia guidelines. So we did away with that terminology and reframed the diagnosis and the common organisms and empiric antibiotics for our providers. We then focused on IV to oral conversion as another way to try and improve the antibiotic use and hopefully try and get our patients out of the hospital more quickly when they were clinically stable to go home. And then we focused on duration of therapy. Again, the bulk of the evidence suggests in patients who respond and clinically have an expected course for community-acquired pneumonia, that 5 days really is the shortest effective duration that's known, and that you probably don't need more than 5 days in the vast majority of patients. So again, we were didn't focus on a diagnostic intervention here, but more of an empiric antibiotic focus, trying to minimize excessive broad spectrum use, excessive IV use, and then trying to get to a duration of 5 days. Next slide. how this sort of works and how in our hospital patients actually get into this pathway is that we have Epic as our electronic health record. And when a emergency room provider goes in and orders a chest x-ray and an antibiotic within the same encounter, this best practice alert or BPA pops up that says, is this antibiotic for pneumonia? Here, now it calculates the CURB 65 score, but here's how you calculate the CURB 65 to think about triaging them if this is pneumonia. And then if it is pneumonia, here are these order sets at the bottom for inpatient and outpatient pneumonia care that we would go into. So this is the way to trigger the providers to go into the order set and to essentially use our desired guideline. Next slide, please. For our community-acquired pneumonia treatment options, once you go into that guideline, we really have this stuff pre-checked that for floor patients, we sort of go ahead and make it the path of least resistance to get them on our preferred antibiotics for community-acquired pneumonia, which are ceftriaxone and azithro, which we auto-convert, which is a little bit different than most people would do, but we feel comfortable doing it. Auto-convert them on day 2 to an oral antibiotic for a total of 4 days, so that the ultimate total duration that is prescribed from the very beginning is 5 days to give us a total 5-day course. Next slide. We also incorporated what our institution felt were preferred diagnostics for community-acquired pneumonia. Again, the order set is different for outpatient, inpatient ward patients, and intensive care unit patients. But again, we have these things pre-checked to guide providers to what we agreed upon as a multidisciplinary group with the most appropriate diagnostic test for this syndrome. Next slide. Oh, sorry, you can hit next slide again. Thank you. But I wanted to point out, oh, if you go back one, I'm sorry. I wanted to point out that we have actually looked at this, and just rolling this guideline out by itself improved antibiotic use a little bit, but these guidelines and coming back to an agreed upon plan, diagnosis and antibiotic treatment plan for community-acquired pneumonia really gave us the ability to go beyond. And we realized we needed to be doing daily or several times a week prospective audit and feedback of our pneumonia patients. And when we did that, on top of rolling out this guideline and educating folks about it, we had significantly improved antibiotic use and shortened length of stay for our pneumonia patients. Next slide. All right, hand it back to Erin now.
Thanks, Emily. So the next 2 core elements that we will discuss are tracking and reporting, and measurement is critical to identify opportunities for improvement and to assess the impact of interventions. Summary information on antibiotic use and resistance, along with ASP processes and outcomes, should be shared regularly with hospital staff, leadership, and the hospital board. And electronic reporting to the National Healthcare Safety Network Antimicrobial Use, or AU option, is important as it facilitates accurate and timely monitoring and benchmarking of antimicrobial use. Next slide, please. The AU option provides a risk-adjusted benchmark of antimicrobial use called the Standardized Antimicrobial Administration Ratio, or SAR. And benchmarking has proven to be a powerful tool in hospital quality improvement. Antibiotic stewardship programs are using NHSN AU option in the SAR to both inform and assess interventions. Next slide. Hospitals can track SAR data over time and across eligible patient care locations and report findings back to hospital staff and leadership. Next slide. Hospitals participating in the AU option report both antimicrobial days of therapy and days present, so thereby meeting the 4th criteria listed and highlighted in the table below. And 181 critical access hospitals have reported at least 1 month of AU data to the antimicrobial use option so far. Next slide. NHSN provides AU case examples, a SAR guide, and an AU data report, which hospitals can use to identify areas where improvements can be made, see examples of how hospitals have made improvements, assess national AU data to aid in benchmarking, and report these data back to staff and leaders. The 3 of the 4 reporting criteria, which are listed in the table below, only have about 50% uptake among critical access hospitals. So some room for improvement there. Next slide, and Emily, over to you.
Thank you, Erin. So when we think about tracking and reporting, antibiotic use, as Erin mentioned, is extremely important for identifying opportunities for improvement and where antibiotic use can likely be optimized, but also for reporting back as an intervention potentially to show providers antibiotic use and where the opportunities are, but also to show your impact. So it sort of is like a 360 metric. But in addition to antibiotic use, I wanted to talk about other measurements. And again, refer everybody back to the National Quality Partners Playbook that I think helps, again, thinking about some barriers, solutions to getting data, what is some sort of first steps in getting data to track and report the impact of your stewardship program. And they break it down nicely into what they describe as basic, measurement, intermediate, and advanced. And basic, or sort of the first step that they outline, is process measures. And process measures, as many know, are specific steps in a process that lead either positively or negatively to a particular outcome. And so I'm going to talk about a few process measures that you can measure and report in a minute. Intermediate, or sort of higher level metrics they describe, are outcome measure. These are really higher level clinical or financial outcomes that may be relevant or are relevant to the C-suite or administration or leadership in your hospital, and to providers, right? If you try and tell a provider, it's just sort of describe to them quantities of antibiotic use, that's not as meaningful to them as telling them how their patient did clinically or how all of our pneumonia patients did overall when we made this change in how we use antibiotics. And then they describe antibiotic use as advanced. I'd say antibiotic use is really a core measurement that needs to happen for stewardship programs. And I view it really as a process or an outcome measure. So antibiotic use and measuring it to me is a process. And decreasing antibiotic use is a process in the pathway to improving our clinical outcomes, but it's really also an outcome measure because I report it, and it's what we are partly directly measured on, is how much are we reducing certain antibiotics. And so again, it is a process and an outcome measure. Next slide. So I wanted to give some examples and think about these interventions and how you can set up your interventions potentially to make your measurement a little bit more seamless and less burdensome. So at the University of Utah and at the Salt Lake City VA, when we initially started our programs and started doing a lot of prospective audit and feedback, we created the ability to document, and we don't do all interventions, but our highest sort of clinical impact interventions, to document a progress note for those interventions where we capture discrete data such as the drug that we were reviewing, what the indication was for that drug. We would, free text an assessment or sort of our recommendations, but then more discreetly capture our recommended interventions, such as narrowing the spectrum of antibiotics, stopping it if we thought the patient was not actively infected, or if maybe they had completed therapy, switching from IV to PO, if an ID consult was recommended, or changing the dose. Next slide. And what capturing this data in a structured format like this allowed us to do was then go in and very seamlessly with our informatics colleagues get help in pulling a report of essentially the types of interventions that we were making. So from those notes, we could look over time and say, what are the most common drugs, just in simple counts by quarter, that we intervene on? And so you can see here, this is older data, but when we first started, not surprisingly, vancomycin in the pink, and piperacillin and tazobactam in the pink and vancomycin in the green were the most common drugs that we were leaving these notes on or doing these types of interventions. Next slide. And then we were also, you're also able to sort of pivot and look at this data in different ways. And so we were also able to see, well, what are the most common interventions that we make? Not surprisingly, in orange over time, the most common intervention is to narrow the drug, but second most common is to stop in the light blue, which is tapered off over time as we have educated and trained people and got them to think like us. But this really highlighted to administration and to leadership the role and the benefit in us doing this, because we were able to show that this is really necessary, and we make a lot of these interventions over time. Next slide. And so thinking about, so those are process metrics and a way to measure them and report them. Thinking about outcome measures that you may want to think about tracking. Over time, antibiotic resistance patterns, that is usually done by collating an antibiogram through the help of your microbiology colleagues. Clostridium difficile infection rates over time. And I would encourage you, as you probably already know, to work with your infection prevention and control colleagues. They usually already have this data. And so that's a way to harness that relationship and get access to that data. We look administratively in our hospital, and then you can break it into some units or by diagnosis, our 30-day mortality and readmission rates for common infections. Look at length of stay, potentially adverse drug events. That's a harder metric to track, but something to considering looking at if you get down the road and get more savvy. And then I would not underestimate the power in tracking financial data if you can get it. Showing potential cost savings, less so nowadays in antibiotic use, but in length of stay and some of the use of expensive diagnostic tests can really show the impact and the value of your stewardship program, and then can be leveraged for resources to support your pharmacy and physician leaders down the road. Next slide. So just getting back to metrics and things that we were able to follow for the community-acquired pneumonia intervention that I explained in the action section. So tracking our antibiotic use data and having access to AU data was really helpful for us. And we've had it visualized internally on a dashboard, but you can see on the units on the left where we rolled out this community-acquired pneumonia guideline coupled with prospective audit and feedback, we intended to get people to use less ceftriaxone quantitatively because we only gave one dose of it. And you can see over time that that falls as our cefuroxime on the right use increases, because we were trying to get people to switch to oral antibiotics very quickly. So this was useful to show that the process was working as a process measure. Next slide. We then also looked at other process measures as some of our laboratory diagnostics that we wanted used or were pre-checked as part of this pathway, and also our clinical outcomes. And on the left, you can see pre-intervention, and on the right, post-intervention, that we increased the uptake of the diagnostic tests that we wanted used for community-acquired pneumonia. We decreased our duration of IV antibiotics, again, showing that the guideline and prospective audit and feedback were working. And then more importantly, were the clinical outcomes that really helped us show the impact and the value of our stewardship program to our administration. This was the decrease in length of stay, stable mortality, stable 30-day readmission, and a significant cost savings. Here you see a relative mean cost, but essentially showing that the relative cost for these patients went down with this intervention. Next slide. And so I wanted to give an example also of a report. So for an individual intervention like I just described, we would report the outcomes of that particular intervention, but we also have yearly reports that we compile. Again, I'm happy to share. And this is an example of the sort of first page of our Salt Lake City VA stewardship report. And examples of things that you might include, like you see here, are we look at our sort of percent antibiotic change over time. So our program started in 2013. So we compare years to where our antibiotic use essentially was in days of therapy per patient days, days present. In 2012, before we had stewardship, to as we have rolled things out. We look at total antibiotic use and show people that change over time. We also look at antibiotic use by specific classes. And this data, we could expand on it, or I could explain it to you, but it makes sense to me as we have sort of seen and focused on some decreases in broad spectrum antibiotic use and increased antibiotics that are more narrow spectrum over time. Next slide. We also show this data, and this is a similar way to show it, but just more visually, looking in the yellow bars over time are our total antibiotic use per year in days of therapy per patient days present. And then the lines are different classes. So again, looking at anti-MRSA drugs, the community gram-negative drugs, multi-drug resistant gram-negative drugs, et cetera. So this is a way to show folks, look, there's been good impact. We changed total or dropped total antibiotic use over time, and things that we focused on, such as our anti-MRSA and broad spectrum gram-negatives, have decreased as we intended them to. So these are examples of a yearly report that you might provide to your leadership. Next slide. And I'll hand it back to Erin there.
Thanks, Emily. So the last core element is education. Education is most effective when paired with interventions and measurements of outcome. So case-based education can be especially powerful, and prospective audit with feedback and pre-authorization are both good methods for providing AU education. This can be especially effective when the feedback is provided in person, for example, through handshake stewardship. Next slide, please. Education is currently the core element with lowest overall uptake, although nationally uptake has increased from 62% in 2014 to 93% in 2019. And across all facility types, nursing staff are less likely than prescribers and pharmacists to receive AU education. Next slide, and then Emily, back to you.
Yeah, so, I wonder sometimes about this data that Aaron just presented, and if people aren't actually realizing the education that they are providing. And Aaron highlighted it, that people need to think about that prospective audit and feedback, it's an intervention to improve antibiotic use, but it's also an educational tool. So there's a short-term goal and there's a long-term goal in trying to educate. So I'd implore people to think about and think creatively and realize that prospective audit and feedback and handshake stewardship, which we can talk about now that COVID's here, but pre-COVID, we thought about it as a way to really get face-to-face with our providers and do a lot of education at the time that we're making an intervention. This type of intervention education has significant impact, in my opinion, and based on some data. And so I'd encourage you to think about that as an educational opportunity, and you sort of get double bang for your buck. You're doing an intervention and education at the same time. There are other types of education, or clearly like presentations to stakeholders and house staff. So for our community-acquired pneumonia care pathway, we did many layers of education. So one way to think about education with a particular syndrome-specific intervention is we did a lot of lectures and didactics with nursing groups, with our pharmacists, and with hospitalists ahead of time to explain why we were doing this intervention and some of the sort of infectious diseases specific components and data behind the intervention. We then also did education going forward through prospective audit and feedback, as I talked about. We reviewed these patients, and when people were deviating from the guideline, we went and explained why and re-educated them. We then also, on the right is an example of something, literally a card that we printed and laminated it and put it on the screens for nurses to see, for pharmacists to see, and for physicians to see, to remind them about this intervention, very quickly provide some educational pieces and points that we wanted them to realize and take home the biggest impact, or the main take homes of our guideline and our intervention. And then, as Aaron mentioned, thinking now about COVID clearly, and we don't do face-to-face handshake stewardship anymore. We had planned to develop a meeting weekly with our pharmacist on our medicine floors to do handshake stewardship, and COVID came around, and clearly that's changed. But now we devised a different way to do it in a more creative, and we do it on Zoom, which is not ideal, but it's been better than nothing. And so we have antimicrobial stewardship grand rounds with our medicine pharmacists, soon to expand to our physicians, every 2 weeks. And we alternate between doing a didactic that's 30 minutes 1 week, and then 2 weeks later we do a mini didactic very quick, and then just run through cases and answer questions. So I'd encourage you to think creatively, use technology, to think about continuing a lot of this education even though COVID is here. Next slide. And I think that's it, and we'll wrap up, and maybe we have a few minutes for questions.
Yeah, this is Arjun. We do indeed have a few minutes. So if you have questions, please chat them, or not, sorry, please type them into the Q&A section, not into the chat. We are monitoring the Q&A, and we do have a question. And there's one that a question here, and I'm going to take part of it, and Aaron would like you to take part of it. The question is, currently critical access hospitals are not required to report into NHSN. And the first part of the question is, will NHSN reporting be mandated for critical access hospitals in the near future? You know, in the National Action Plan that I talked about, we do have a goal of having all hospitals, including critical access hospitals, reporting data on antibiotic use and eventually antibiotic resistance into NHSN. But there are no plans right now to make any of that reporting required. This is right now voluntary reporting, and there are no plans to require it. We are simply working to help people understand why it's important, and we're going to continue to build on the success that we've had Almost 2,000 hospitals have submitted data into the antibiotic use option of NHSN, including many, many critical access hospitals. And we will continue to work hard to grow that, but we don't have, there's no plan for a mandate for reporting antibiotic use data in the foreseeable future that I know of. And the second question, Aaron, would love it if you could comment on this. It says volume in reporting for critical access hospitals may be low, referencing the NHSN AU option. How do hospitals best use the standardized antimicrobial administration ratio and also the standardized infection ratio?
Yeah, thanks, Arjun. So good question. While there aren't a ton of critical access hospitals reporting, the number is growing over time. So we do have 181 critical access hospitals that have reported to the AU option, which is considerable. And many are included in our STAR models. So we do adjust for facility type. So our risk adjustment takes into account facility type, so whether it's a critical access hospital or not. And in terms of, maybe low numerators and denominators, so it might not be as useful for some hospitals to look at monthly STAR data or SIR data, just because, the number of days of therapy or days present might be low, so it might be more useful to look at quarterly or even, every 6 month or year, yearly data, and just pooling at a higher level of aggregation might just provide a little bit more information on how antimicrobial use that is observed compares to what is predicted by our models. Hopefully that answers the question, but yeah, I think hopefully we'll continue to get increased reporting from critical access hospitals in the future.
Perfect. A question here, this is a really good one. How are adverse drug events captured, and how does that help with stewardship? And certainly adverse drug events are an important aspect of drug safety and antibiotic safety. So let me see if Emily has any thoughts or ideas on how stewardship programs might try to capture adverse drug events and use them to inform stewardship efforts. Emily?
Yeah, I mean, that's a great question. I think an easy one is Clostridium difficile rates, which depending on, I guess, your frame of reference, can be viewed as a potentially avoidable adverse drug event. So that's sort of the lowest hanging fruit way. Otherwise, it is hard to capture. So it'd have to be something you think about prospectively quantifying. There's very good evidence that probably 20%, upwards of 20% of inpatients in the US who receive an antibiotic, whether it's for an infection or they don't have an infection, will have an adverse drug event. So it's hard to capture, though. You would have to sort of go back retrospectively, probably define a syndrome that you want to look at, or maybe just say all cases or all patients who receive vancomycin or receive vancomycin and piperacillin tazobactam, and define an outcome that you want to look for. I would encourage to think about things like potentially renal failure that's unexplainable, diarrhea, allergic reactions, things that tend to get documented and are more easy to capture. Another way may be, although it won't be probably collected in any exhaustive or there will be some reporting bias, would be potentially some patient safety events. That may be another way to work with your quality or patient safety group to see if there's any trends there. And the clear sort of impact of this, or reason to care about it, is it's another opportunity to show potential, if we improve or avoid these antibiotics, we will improve patient safety and may, avoid some emergency room visits or readmissions. Another opportunity may be around unnecessary catheter use. It's a sort of out of the box way to think about this. But if patients are getting antibiotics via or OPAT, or outpatient parenteral antibiotic therapy, that may be another way to think about if I avoid the catheter by avoiding the antibiotic or using oral antibiotics, is that an opportunity to reduce PICC line related infections or readmissions or repeat visits to the ED for catheter malfunction or clots?
Thank you, Emily. And with that, we've come to the top of the hour. Phenomenal presentations, both from Aaron and Emily. Thank you guys so much for all of that great content. And we look forward to connecting with everyone in the future. I think you have all of our contact information, but please do be in touch if you have questions, comments, or ideas for us. We are always eager to hear from folks about things that we can do to help further your efforts to improve antibiotic use. And with that, Monica, let me turn it back over to you and see if there are any closing comments.
The only thing for me is that I went ahead and put the CE information for those of you that asked in the chat box. So go ahead and take a minute to take a picture or copy and paste it. But other than that, that is all I have for today. And thank you everyone for attending, and have a good rest of your day.